I'll go through 4 different clinical tools doctors use to help patients and doctors decide if adjuvant systemic therapy is the right thing for them. These are the CPS and EG score, the Nottingham Prognostic Index, the Predict scoring system, and lastly, gene profiling assays. In a previous video, which I'll link here, I'll go through what you need to know about early breast cancer. There's 3 groups of factors to consider when deciding on treatment. Patient-related factors, so patient's age, frailty, and menopausal status. Tumor-related, such as the nodal status, tumor size, grade, molecular markers, and genomic profiling assays. So treatment-related, systemic treatment given and the response obtained, as well as any local regional treatment. The EPS and EG score is a validated clinical tool used in breast cancer, especially after neoadjuvant chemotherapy, to estimate the risk of distant cancer recurrence and guide further treatment decisions. CPS stands for the clinical and pathological stage, so before and after neoadjuvant therapy, and EG stands for estrogen receptor status and tumor grade. The score combines 4 factors: the clinical stage before treatment, the pathological stage after neoadjuvant therapy, the estrogen receptor status, so whether it's positive or negative, and the tumor nuclear grade, 1, 2, or 3. Each factor is assigned a point. The total score ranges from 0 to 6, with the higher scores indicating a higher risk of distant recurrence and a worse prognosis. Here is an example of the scoring table. A score of 0 to 1 indicates lower risk of recurrence and a better prognosis. A score of 2 to 6 indicates increasing risk of recurrence and a worse prognosis. The system helps clinicians refine prognosis and select patients who may benefit from additional therapies after surgery. The CPS and EG score is especially useful for patients with hormone receptor positive or triple negative breast cancer after neoadjuvant chemotherapy. It provides more detailed risk stratification than using clinical or pathological stage alone. The higher EPS and EG score indicates a greater risk of cancer returning at a distant site. The Nottingham Prognostic Index, or NPI, is a widely used tool to estimate prognosis after surgery for breast cancer. It combines 3 key pathological features: the tumor size in centimeters, lymph node involvement, and tumor grade. The NPI is calculated using this formula. NPI is 1/5 of the tumor size in centimeters plus the lymph node score plus the tumor grade. So for lymph nodes, 0 nodes is 1 point, 1 to 3 nodes is 2 points, and more than 3 nodes is 3 points. For tumor grade, grade 1 is 1 point, grade 2 is 2 points, and grade 3 is 3 points. Based on the total score, patients are grouped into prognostic categories. A score of 2.4 or less indicates excellent prognosis. Between 2.4 to 3.4, it indicates good prognosis. 3.4 to 5.4 indicates moderate prognosis, and above 5.4 indicates poor prognosis. Lower scores indicate better outlook, while higher scores suggest a higher risk of recurrence and lower survival rates. This tool helps guide decisions about additional treatments after surgery, such as chemotherapy or radiotherapy. Other factors to consider outside of the NPI tool are age, premenopausal or postmenopausal status, hormone receptor positive or negative, whether the tumor has lymphovascular invasion or not, whether it's HER2 positive or not, and the Ki-67 score, so whether it's less than 15% or more than 15%. The next tool we'll discuss is the Predict tool. It's an online prognostic tool developed by the UK National Health Service to estimate survival outcomes and the benefit of adjuvant therapies for women with early-stage invasive breast cancer. The tool requires patient and tumor details, so the age at diagnosis, the tumor size, the grade, the number of positive lymph nodes, the estrogen receptor status, HER2 status, the Ki-67 status if it's available, the mode of detection, whether it was screening or clinical, and any planned treatments. It then gives you an output which predicts overall and breast cancer specific survival at 5, 10, and 15 years. It estimates the absolute benefit of different adjuvant treatments. It helps in treatment decision-making by helping patients and clinicians weigh the potential benefits and harms of additional therapy after surgery. The model has been validated in multiple international populations and is updated regularly to reflect advances in breast cancer care. Gene profiling assays are useful in hormone-positive and HER2-negative subtypes to determine the molecular subtype, whether it's luminal A or B, and guide on risk of recurrence. A commonly used predictive gene profiling assay is Oncotype DX. The Oncotype DX recurrence score stratifies hormone receptor-positive breast cancers into risk groups, integrating tumor biology to personalized treatment. It's a 21-gene panel. It's approved for use in hormone receptor-positive, node-negative, and HER2-negative intermediate risk patients, so those with an MPI score of 3.4 to 5.4, if it's considered to help with decision-making process. It gives a score between 0 to 100. Under the age of 50, the score bands are as follows. Lower scores are from 0 to 25 and favor endocrine therapy alone. Intermediate scores are 16 to 20 and have around a 1.6% benefit of chemotherapy, with higher scores from 21 to 25 having around a 6.5% benefit of chemotherapy. This range warrants a risk-benefit discussion with the patient. Higher scores above 26 indicate chemotherapy benefit, particularly in younger patients. Oncotype DX is increasingly used in those above the age of 50, postmenopausal women, N1 positive, hormone receptor positive cancers. Over the age of 50, it's categorized into low and high, with 0 to 25 being low risk, indicating minimal benefit from chemotherapy, and high being 25 to 100, indicating that a patient is likely to benefit from chemotherapy. Here's an example of what the scoring report looks like. Key components of the report are the recurrence score, which predicts distant recurrence risk within 9 years for node-negative patients or 5 years for node-positive patients with endocrine therapy alone. Then you have the absolute chemotherapy benefit, which estimates the percentage reduction in recurrence risk when chemotherapy is added to endocrine therapy. Oncotype DX is used as both a prognostic tool to identify patients with low risk who can safely avoid chemotherapy, and a predictive tool to guide chemotherapy use in high-risk patients. This test costs $4,500 in the US, though often covered by insurance. It takes around 10 to 14 days to come back, and it's not validated for use in HER2 positive or triple negative breast cancer. That's all for now. I hope you find that helpful. If you do, please comment, like, share, subscribe, and let me know what you'd like me to cover next.